Yes.
Well, good morning, good afternoon, everyone. Welcome to today's webinar. It's my pleasure to introduce Dr. Michael Miller, who is a board-certified addiction psychiatrist and is certified in addiction medicine by the American Board of Preventative Medicine. He is a distinguished fellow of the American Society of Addiction Medicine and a distinguished life fellow of the American Psychiatric Association. He's also a world-renowned lecturer who we have the pleasure to hear from today. If you have any questions for Dr. Miller, please enter them in the Zoom Q&A. Dr. Miller, thanks for your time. Please take it away.
Yeah, I'm trying to screen. I thought I just should. Come on. No, it says I'm screen sharing. There's nothing to share. There we go. There we go. So why is it doing this? There we go. Great. So there we go. Can you guys see that?
Looks great.
And you can no longer see me, right? Or did you put us side by side? Doesn't matter to me.
Yep, we can see you as well.
Cool. You guys got good stuff. Oh, by the way, Nicole, thank you for your assistance. I went into a first link and this one's better. So thank you very much. Hi, everybody. My name is Mike Miller, and I've been practicing addiction medicine for 40 years, and I will be coming out of retirement soon. I hope maybe within a couple of weeks to join the faculty at Loma Linda University and the medical staff of the VA hospital in Loma Linda, where I hope to do a lot of clinical teaching for addiction medicine fellows, residents from various departments, and medical students. But currently, I still have a position at Medical College of Wisconsin, and UW back to 1985, and I was just completing one of the many, multiple, interminable applications for the. So I was going through all of this stuff and look at all these dates. So this presentation is based on not only my 40 years experience, but efforts to develop a definition of addiction which would say that this is not just people behaving badly. This is a real brain disease. And a group got together in the doctors who were just concerned about the status quo. And I think we started our work in 2008, finished it, and the same definition of addiction, which was approved in 2011, has now been replaced by a newer one that's much briefer. And I understand that. But the work we as a bunch of clinicians did to develop this included talking to neuroscientists and the science. I've given this presentation a few dozen times to all sorts of different audiences. I think the slide deck will work well for you guys, but if we have extra time, we can jump to a different one and drill down a bit more. Okay, so what really is this thing that's called addiction, especially since we hear about things like chocolate addiction and all sorts of addictions. Internet addiction is real. A lot of behavioral addictions are real. Chocolate, probably not. But we're going to, I think, learn more. We don't know enough about nutrients and addiction. And as you've all read about, high fructose corn syrup and whether that is such a potent reward that it may be some sort of trigger for actual addiction. But that's really complicated. So, but what is it really? Well, let's start with what it's not, okay? It's not just a social problem. It certainly affects communities and the nation. It affects families. It involves human interaction. But to say it's a social problem says it's not a medical problem, and that's not really accurate. It's a criminal justice problem if you make drug use illegal. And considering the rates of incarceration in the United States and how much of that is related to drug laws, it's a huge problem. And that makes it a problem for all sorts of budgets. It's even a problem, most municipal budgets. There's a high cost for the city or county jail, and a huge amount of that is alcohol and drug related, just from intoxication and domestic violence related to intoxication. So, I mean, yeah, it's all sorts of a problem. But to say it's only a criminal justice problem, that's reductionistic in a way that's really not helpful, because we're never going to incarcerate away this problem. Now, can we say it's a psychological problem? It's a behavioral issue or a cognitive issue? Well, it's probably a lot more than that. It's certainly more than a habit. And it's unfortunate when people talk about somebody's heroin habit. You have a habit of injection drug use. It's habitual, it's repetitive. The behavior itself is reinforced. But really, there's an active ingredient involved. And in addiction, there's a very potent reward. Now, you can have a big debate about whether people can get addicted to needles. That's a really interesting thing when you really work with a lot of patients. And a lot of patients say that's what they feel is going on. They get such a rush from the whole injection process. Now, it does become ritualized. It can become obsessive. But again, just calling it a psychological problem is risky because, sorry, all you psychologists out there, psychologists are taught to do what psychologists do, and that's fine. And psychotherapy is wonderful, and testing is wonderful, and the skills of psychologists are wonderful. But I'm a psychiatrist. I'm board certified in psychiatry, and most psychiatrists consider me to be sort of an anti-psychiatry psychiatrist because I learned at the very beginning of my career that psychiatry and treatment weren't helpful. And I'm going to say that you can't learn addiction away. And psychologists look at addiction as a learned behavior. Many psychologists look at addiction as a learned behavior, and learning, you can unlearn it. I think that's reductionistic and doesn't deal with the incredible scope of addiction. Now, obviously, we also have a lot of people who consider addiction to be a sin. Your morals are affected. Your values are affected. It is a problem with your values and your sense of meaning and your spirituality. But to say, now, it's real reductionistic, very reductionistic, to say it's not psychological, it's not biological, it's not social, it's purely spiritual. That's, I think, a bit of a stretch. It's not just an individual problem. It does involve families and communities. It's definitely a medical problem, and we'll talk about that to some extent, but it has many other impacts on the individual, the family, and the community beyond just the biology. It is truly a biopsychosocial spiritual condition that involves all dimensions. Sadly, the new ASAM definition that replaced we were the first medical society that I know of to put spirituality in the definition of an illness, and the board of directors said, let's just take that out. It's not worth arguing the point. But at any rate, it's biopsychosocial, spiritual, it's everything. But if you look at it in terms of people behaving badly, then it's a behavioral problem. It's a social problem. You might make it a criminal problem. But if it's just people behaving badly and you don't look at the underlying neurological substrate, you've missed the boat. And again, this is how the ASAM definition of 2011 was conceptual. The idea was birthed, and then the process to develop the definition. Now, going back to Latin, it has to do with attachments. It's a pattern of unnatural rewards, or it can be an unnatural attachment to natural rewards. The rewards that it's healthy to be attached to are nutrition, hydration, socialization, procreation. Those are things that, if we're attached to those things, it's good for us and it's good for keeping the species going along. And we have our midbrain reward circuitry thank God we've evolved that, because that does allow for important rewards to be reinforcing so that we do them repeatedly. The problem with addiction is you get attached to unnatural rewards, or you get attached to food or sex or spending pathologically. And I think looking at things in terms of attachment is important. Now, this is not to say that I'm a psychologist who's well-versed in attachment theory, but I do believe that all the people that say that the opposite of addiction isn't sobriety, it's connectedness, that I will endorse. Sobriety is really important, but it's connection that brings people out of this. And I mean, AA, going back to 1935, it talks about a lot of things, but it really talks about connecting with people. So the biology is insufficiently emphasized and largely misunderstood. And I think even most physicians, if they understand something about neurobiology and addiction, they're focused on what they learned in school, which is that in the 1950s, Olds and others came up with this idea that there is a reward center of the brain where stimulation, you can get lab rodents to do some really strange things that they wouldn't normally do. So reward circuitry has been identified. It's not really a center, it's more the interconnections, but that is not addiction. Addiction is broader than that. And we're going to see, if I have in this slide, some of those details. So the behavior of people who have this disease is different than the behavior of others. I'm not going to say it's behaving badly, but certainly it's dysfunctional behavior. It's helpful to the individual or anybody around them. They behave because the brains are different. The brains of people with addiction function differently than the brains of persons without addiction. And we'll talk about the functioning of the addicted brain. So this was our short form. And the most important word that they didn't carry over, and it's just beyond me, I'm just so disappointed. Primary, it's a primary illness. It's not secondary to something else. It's a disease in and of itself. It's not caused by drug use. There's something that happens in lab animals that the basic scientists call a model of addiction that does seem to result from chronic drug exposure. But I'm going to present to you the thesis that you need to have a predisposition for drugs to cause your brain to change. But maybe with the exception of the really intense rewards. And those are amphetamine and nicotine. Maybe you can take somebody with no predisposition, give them enough cigarettes and get them addicted to nicotine. I think that's certainly possible, but I don't think it's possible with alcohol and sedatives and cannabinoids and opioids. But there was a definition of alcoholism developed by some organizations that no longer exist. One was the National Council on Alcoholism that did close its doors in the last 5 or 10 years, and then it partnered with the American Society of American Medical Society on Alcoholism and Other Drug Dependencies, which is a predecessor organization of ASAM. In the late 80s, they came up with a definition. It was published in JAMA in 1992. Authors Moore, Simo RSE, and Flavin, FLAVIN. And the JAMA article goes through every word in that definition and says why they're there. And it says why primary is in there. It says why chronic is in there. It says why denial was in that 1990 definition. So addiction is caused by itself. It is a primary disease. It's not caused by, as I say, it's not caused by a bad mood, bad luck, well, bad luck, bad back, not by a bad spouse, not by a bad president. It's caused by itself. And it can lead to problems with your marriage and your back and other things, but okay. So it's a primary chronic disease. I'm gonna go backwards. Of brain reward, motivation, memory, and related circuitry. Now, where do we come up with that? The biology that's misunderstood is that most people think that if you understand the reward centers, you understand addiction, but you don't. You understand intoxication. You have to have the interconnections to the amygdala, where motivation happens, and the hippocampus, where it happens, and the frontal lobes, where inhibition happens. You need to have those connections. It's those connections which develop, which lead to behaviors that are easy to describe. So dysfunction in these various circuits leads to characteristic manifestations of this primary chronic disease. Those can be biological, psychological, social, and spiritual manifestations. What you end up with is an individual who's pathologically pursuing reward or relief by substance use and other behaviors. So that sentence is jam-packed. And what it means is that some people use alcohol and drugs for reward, and some use for relief, but most use it for both. And so a cliche is that people use drugs for relief, and they use stimulants and hallucinogens for getting more activated and having a broader range of psychological experiences. So stimulants and hallucinogens for reward, opioids, sedatives, alcohol for relief. That's not a bad formulation, except that it's just a description of something that happens maybe early in the course, and maybe that it has to do with drug choice and early involvement with chemicals that end up being unhealthy for you. It's important to recognize that with addiction, there is a progression, and people begin using for positive reinforcement. They end up using for negative reinforcement. What that means is that, and again, negative reinforcement is not punishment. Positive reinforcement means you do something and something good happens to you. Negative reinforcement means you do something and you get punished. Did I say, no, that's punishment. With negative reinforcement, it's not that you do something, it's that you have something and you do something to take it away. You do something to give you relief. And the relief is a profound psychological pain that is due to dopamine absence. And you relieve it by healing, or acutely by providing another dopaminergic agent to get out of this mess. Now, people with addiction to chemicals can have different forms of withdrawal syndromes. The withdrawal syndrome from alcohol and sedatives looks like you're on speed. The withdrawal syndrome from speed and cocaine looks like you're crashed on Quaaludes or Xanax bars. The withdrawal syndrome from opioids obviously involves hyperalgesia everywhere and hyperactivity and agitation. So that's the physiologic withdrawal, and that can be uncomfortable enough. And you may want to use your usual drug to get relief from the withdrawal syndrome from that. But with all of these chemicals, there's dopamine withdrawal, and that's the real pain, and that's really the driver in opioid addiction. The return to use to get rid of the opioid to get rid of the dopamine withdrawal that comes, and also that's true for all stimulants. It's true for all drugs. So, and then so we described non-substance addictions, and we described reward and relief, and we described the brain as in addiction as involving more than just the reward circuitry, and we described biological, psychological, social, and spiritual manifestations. So the second paragraph of our short definition was the characteristics are an inability to consistently abstain. Now that means that you can quit anytime. It's just that you go back to it. So you can, consistent abstinence is the problem. And it's a return to use after periods of abstinence. It's a return to use despite adverse consequences. So Impairment in behavioral control, meaning you lose control some of the time when you use your drug. Now, actually, most people with addiction involving alcohol use control their use about half the time or more early on. As the disease progresses, you have loss of control with smaller exposure and the shorter time interval in between. Again, loss of control is you plan to have 3 and you have 13. You plan to have 1 line of Coke and you go to the ATM machine and get more. And of course, speaking ATM machines, loss of control is I'm going to go to the casino for an hour and you stay a day and a half and maybe run up a 5-figure debt from your ATM machine. Loss of control. Again, most people can control their use, and then they use the fact that they are a controlled user a significant amount of the time as evidence that they're not over the edge. That is not the case. You don't have to drink every day to be alcoholic, and you don't have to lose control every time. But there's clearly a loss of control. There's craving, which is conscious and your brain knows it, but also it's deep in your brain chemically, even if it's unconscious craving. There's a diminished recognition of significant problems with your behaviors and interpersonal relationships. That very wordy phrase was written by me in my classically verbose way, but it says what we want to say. It's not denial. It's just you don't see it all. You have a diminished recognition of problems with what you're doing and how it affects your others. In this disease, everybody else knows about it before the person with the disease. Knows that you have a problem and that your relationships are problematic, and you don't see it. And the recovery process involves coming to that very first step of recognizing that your life is unmanageable, and it has a. And the dysfunctional emotional response is a fascinating brain phenomenon, which I knew nothing about until I began talking with the neuroscientist 15 years ago as we were doing this. And I hope to get back to that because it's really important. So it's a chronic disease, meaning that there are cycles of relapse and remission, which means you shouldn't freak out at relapse. People have relapses with asthma and with diabetes, and they have relapses in arthritis, relapses in lots of things. And they don't get blamed for it. Which is, the real tragedy. It's progressive and can result in disability or death if you don't do something about it, intervene in some way with professional help or recovery activities. So that was our definition. Now let's go into the new understandings. We know something about how the brain is different in addiction. We know that dopamine and the ventral tegmental area, the nucleus accumbens, are important. This is the reward pathway that was known, began to be understood in the 50s, which is 60 years ago. And we've learned more and more and more about it. And the reward pathways are actually a little more complicated than just the nucleus accumbens through the median forebrain bundle up to the ventral tegmental area. I'm sorry, PTA is where it starts, projected through this bundle of axons known as the median forebrain bundle up to the nucleus accumbens, because some addictive drugs actually don't work directly on the VTA, they work somewhere else, but their final destination for all of them is the nucleus accumbens, which was again called the reward center for a long time. It's best to talk about all the interconnections, but anyway, what else do we have? The nucleus accumbens is where reward happens. Dopamine is released from the nucleus accumbens and goes to your brain to tell you you're happy. So that's the kick from champagne. That's the buzz from any drug. That's the joy of sex. It's the joy of anything. It's the joy of a sunset. It's the joy of a wonderful meal. It's the joy of all sorts of things. And I would imagine you get a, I hope that's not you, is it, John, calling me saying there's something wrong with the tech?
Nope, there's a question that's come in, but we can
Oh,
can
no,
do that
I'll
now.
just let the phone ring down there. That's as long as you're not trying to reach me saying, oh my God, the tech's not working. Okay. So I imagine somebody who hydrated and first gets water, also besides getting the biological hydration, I bet their cortex has a lot of dopamine set after only got a drink of water. Think about that guy that came off that boat that they found. He had all sorts of dopamine going up to his cortex to make him aware of what was going on. So the ventral tegmental area and the nucleus accumbens and the connection between them, called the median forebrain bundle, is the basics of the reward circuitry. But but that's unconscious. You have to have connections up to your cortex to let you be aware of what's happening down there. And the prefrontal cortex in this cartoon is a little bit of now known. What's now known is it's a hell of a lot more than just this. But as I said, food, water, sex, and nurturing your young are rewarding behaviors. And so hugging your kids or hugging each other gives you a nice dopamine rush. That's why we do it. But if we do those things, also the species will move forward. So addiction is use, sorry about the D, is used despite adverse consequences, returning to use after periods of abstinence, even with previous life catastrophes, inability to consistently control use, cognitive preoccupation, plus conscious and unconscious craving. These are all the things that we know happens. But what are the brain areas that lead to that? That's what we're going to touch base on today. It does involve memory, judgment, executive functions of planning, and deciding to defer gratification. For gratification, they go for their reward. And that's why their family may say, you're selfish. All you want to do is use your drug, even if that drug is video poker. But again, you're putting this ahead of everything else. Yes, they are, because that's the way the brain works. It's the salience part. The site of action for euphorians is the nucleus accumbens. It's a bit of an oversimplification, I said, but anything that'll give you a buzz eventually does release dopamine from the nucleus accumbens and then goes up to the cortex and says, I'm happy. Well, it exists in the hippocampus, which is the seat of memory, and thus the seat of conditioned cues to use. In addiction, there's a very powerful cue response. This was learned best in the 80s when researchers were trying to figure out what's this cocaine epidemic we have and why is cocaine such a powerful reward. And it was learned that there is this memory component with cues to use. And so people can get a dopamine rush from using cocaine, or from looking at a pile of cocaine, or from looking at a movie of cocaine, or from looking at a pile of money they'll use to buy cocaine, or looking at injection equipment they've used to shoot up cocaine, or equipment to freebase cocaine. There's a lot of things other than cocaine that's related to cocaine use that's a conditioned cue that says, I should anticipate a big dopamine release in just a second from my cocaine use, but you get those things even before you use the cocaine. So the hippocampus has to remember all of these things and to tell you what to anticipate. The amygdala is the seat of motivation and prioritization, and thus salience. So what is salience? It means that one reinforcer takes center stage over everything else. Salience actually is, on the 50-yard line, halfway up the middle. It is the thing. It's the thing that the spotlight is on. Use whatever metaphor you want. It's bigger than your BFF. It is the number one reinforcer. Now, usually, of course, food and water should take precedence, and sex. Those are biggies. But with addiction, that circuitry gets hijacked in something. So motivation has to do with your drive to do something, prioritization. is what's your motivation hierarchy, what comes first, second, third, fourth, what things do you push to the side and exclude and just focus on your drug. All this prioritization and salience comes from the amygdala. Now, a classic scene that is a social problem and a legal problem is this one. Read an article in news any old time you want. A person is or at a bar playing a video poker machine or in a casino while a child is in a car seat in the car and the child burns up to death. And the parent is charged with murder and child neglect, or if the baby is revived, it's charged with child abuse, et cetera, et cetera, et cetera. And everybody goes, oh, what a horrible person, how selfish they are. Let's punish them in the criminal justice system or in other ways, take away their child or whatever. Now, those punishments may make sense, but I look at that scenario from a biological standpoint. Somebody has such intense salience that their drug takes precedence over parenting. It's a matter of prioritization. If you ask that person, do you love your child? They say, sure, I love my child. But they lose control and their emotional hierarchy changes just to their, it can be alcohol, it can be cannabis, it can be opioids, it can be gambling. So, okay. Now, here's the issue also. The frontal cortex is dysfunctional in addiction. It's not functioning very well. It's not doing much to help you use good judgment. It's not doing very well to have you prioritize and plan. It's not helping you with impulse control and foresight. I've heard the frontal lobe described as the organ of what then. You do this, but then what then? Okay. Wouldn't it be fun to go car surfing and stand on the roof of the car? Yeah, but what then? What about the TBI in the nursing home the rest of your life? Without the frontal lobes, you can't project into the future and look at the downstream effects. You can't play the tape forward. You have no tape to play forward without a frontal cortex being able to put things in temporal perspective. I mean, the whole thing in school of write an essay comparing and contrasting these things. It's very hard to do that in elementary school. It's even probably hard to do it in middle school, because to compare and contrast, you have to take a concept and then put it up in the frontal lobe and it's pending. And you take other things and compare it, and you make a lot of comparison judgments. And the frontal lobe doesn't do that very well in addiction. And so you don't have anything to temper your drives, motivations to use drugs. So the site of action for this chronic, recurrent, relapsing disease is the interplay amongst the nucleus accumbens and memory circuitry, motivation drive circuitry, and the frontal lobes. That's it. And I think there's a little cartoon that's going to show this. Yep. This is not new. This is 20 years old. Okay, this is from NIDA, probably 25 years old. So the reward circuitry is in red. And so you have your ventral tegmental area, which they're calling, I think, the ventral pallidum here, but at any rate. And it's connected to the nucleus accumbens, and that's the reward circuitry. But there's a lot more. There's interactions with the hippocampus, interactions with the amygdala, and the interactions with the frontal cortex in a lot of ways. And that's other thing called the anterior cingulate gyrus, which is up there near the frontal lobes. And there's a lot about the cingulate gyrus that I personally don't understand. It's just a little bit beyond me at this point, but I love this cartoon, and I believe this came from NIDA as well. So the brains of people with active addiction are different from the brains of people without it. Somebody without addiction may have a drive, and it may be driven by their amygdala giving them saliency to say, this is the number one thing I'm going to do. And previous experiences with the behavior may come into play. But there's always the frontal lobes providing some level of inhibitory control. And for example, if you have a memory of burning your hand when you touch the stove, even though the melting chocolate syrup is really important and you have a motivation for it, you'll be really careful to avoid the burners because of your past memory of negative experiences. But in addiction, people reprioritize things and don't remember things as well, and will continue despite, even if even if there's a memory, they'll proceed anyway. So because the drive is so great. So if there's reasons not to do it, you won't do it if you have a non-addicted brain. But with an addicted brain, the power of conditioned cues is really powerful. The saliency makes your drug number one. Your drive is completely focused on using, and you don't have any brakes. It's all accelerator, no brakes. And it's all go, 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 and then you do the behavior again and again and again. And I like this cartoon. I hope you like it as well. So it helps me remember really what's happening here. And of course, this is why we recommend that nobody use drugs before age 25, because you don't have a full complement of frontal lobe inhibitory functions. Your frontal lobes don't mature until 25, which is why Hertz and Avis don't let you in a car before 25, because they know that actuarially you're at risk to use the car in a dangerous manner even at 21. So, you know, we've established 18 as the date of majority, but as far as the brain is concerned, it doesn't care about those political decisions. We don't have a full complement of inhibitory functions from our frontal lobes until 25. That's also why it's probably better, if you're going to be fighting a war, to have somebody charging the enemy with a bayonet be under age 25, because it's all drive and no inhibitory control. But okay, so what's the summary of the physiology? Only certain substances. Aspirin doesn't count, Prozac doesn't count, but certain substances, and we'll put those in the classification again of sedatives, stimulants, opioids, cannabinoids, nicotine, and maybe some others. I think there's a lot of debate about hallucinogens, whether they're truly addictive. That's a whole other topic. I would say they're probably not. And that means true hallucinogens. That means like LSD and psilocybin. It doesn't mean the synthetic amphetamines like MDMA. But certain substances have the ability to interact with the brain's reward circuitry, and they produce a buzz. We'll call them euphoriants. They are reinforcing, and lab animals are self-reinforcing. Animals are for us to get this instead of glucose water. Some work directly on neurotransmitters, on receptors. Others cause release of neurotransmitters or alter the level of neurotransmitters. It all has to do with the normal brain being changed when these molecules are introduced. And you end up with a variety of intracellular actions. We're not going to get into cell biology discussion today, but the result is that neurons are activated that connect with the nucleus accumbens. You get your big dopamine release, and then you have a subjective experience of reward or relief, actually. So do drugs hijack the reward circuitry? I think they do. Will the individual compulsively pursue these unhealthy rewards instead of natural rewards? Yes, they will. And that's what addiction is. So once the reward circuitry is turned on, there are changes in related brain areas, and these are the characteristic manifestations. So altered cue response is the hippocampus, changes in motivation, again, is the amygdala. And so your drug becomes the salient reinforcer, replacing other healthy reward. This contributes to preoccupation and loss of control. So this is why people are preoccupied. If you're in a clinical situation, you can ask people about their relationship with their drug. Somebody with addiction will talk about their relationship with their drug. People without addiction will say, what are you talking about? Relationship with your drug. People with addiction, they get that concept. And preoccupation is you think about it all the time. When you're not using, you think about where you're going to score your next supply, where you're going to get the money to purchase your next supply. Can't wait till work is over so you go out and use again. It's a mental preoccupation. Okay. Changes in the frontal lobe are key. The brain fails in its efforts to inhibit the drive to obtain or use the drug to create the high. So your frontal lobes fail and your other systems are hyperactive. And people, again, use in amounts they didn't plan. They get consequences they didn't intend, and they end up with a lot of negative consequences, despite previous experience with negative consequences. They don't learn from their past behavior. Decades ago, I heard somebody say that alcoholism is a disease where people drink and have problems. And then they drink more and have more problems. And then they drink more and have more problems. The disease is continuing to use despite previous experience with negative consequences. Drinking and having a problem means you got drunk and you got a headache and you did something you didn't plan to do. That's just an event. And if you learn from that, that's fine. But if you compulsively continue to use despite adverse consequences, that's addiction. Okay, there's alternate interpersonal relationships. Your social network narrows. You end up hanging around with people who are like you. And then the person comes in the treatment and says, everybody I know drinks as much as I do. Yes, ma'am, exactly. That's exactly what we're trying to say. Everybody you know drinks as much as you do because your social network has shrunk down to people who are in the same situation you're in. Social networks eventually get so narrow that people are just completely alone. People that have studied social networks, you know, when it gets really, really bad, a person with severe persistent addiction, the only people they see are other users and their dealers, and that's it. Letting go of the people who love you and healthy associates is not good. Replacing healthy people with unhealthy people happens in addiction. That's not good. So there's all sorts of social issues. And you end up with a real connectedness problem. And what I teach my patients is that as you get better, each of these dimensions of connectedness helps with the other. And I had a patient once who was an economist, very smart, very intellectual. And he was in treatment. He said, Doc, I'm figuring out what you were talking about. I noticed that when I'm connected better with my wife, that makes me better connected to myself. When I'm better connected to myself, I can better connect with higher power. When I'm better connected to higher power, I'm better connected to myself and with others. These feed on each other, not only in a negative way when you're losing healthy connections, but a positive way when you're rebuilding them. And so, you know, what comes first, what comes last, I don't think it matters. You'll eventually have you're whole again, where you can live with yourself and you can live with others and you accept your place in the cosmos. Well, in the community first, but in the cosmos. But I don't think it matters which one's first, because one of them can drag you forward. Now, of course, faith-based programs all talk about higher power and want to get that connection going first. It works for some people, but as long as you don't just think that's all it's about. It's also human connection and relationships, and it's being functional in society. It's not just your relationship with what you view as your creator. Okay. So again, addiction isn't caused by drugs, it's caused by interactions. The vulnerabilities that people have that are largely genetically transmitted, the comorbidities that make it more likely that you'll develop addiction when you use drugs. So again, it's only certain substances. Also, you know, behaviors can get into this. I mean, you know, food and work can be addictive for that individual. But again, a lot of times you need the trigger, you need the vulnerability, you need there's something with your DNA, something with genetics, actually maybe something with experience. We'll talk about that in just a second. So environmental factors, whether your culture supports or opposes your use, your neighborhood, your household, family. The number one thing is not peer pressure, it's a sibling who uses. So when you're young, the number one factor of whether you're going to use is whether a sibling uses and supports your use, encourages your use, provides you with substances. If your neighborhood has no sources of alcohol or drugs, that makes it a lot harder for you than if your neighborhood is flush. most neighborhoods now are flush with anything. What are the cultural expectations? We have this big issue right now where the perceived harm from cannabis is getting close to zero. That's not a evidence-based position, but so many people have it. They have this notion that if it's less harmful than alcohol, let's just say it's not harmful at all. And it is less harmful than alcohol, but it's not without harms. So culture makes a difference. Your predispositions, I think, are a big factor, and not every substance can do it. You know, aspirin doesn't do it. Penicillin doesn't do it. Digitalis doesn't do it. But, you know, obviously rubbing alcohol does it because it's an alcohol. Genetics is probably 60%, maybe as low as 50, but it's not less than 50. So again, this happens because of your DNA, and addiction runs in families. Some of that is learned behavior. Well, most of it's genetics. In the learned behavior in families is often, I'm not going to use this stuff. I'm going to stay away from it because look at all the pain it caused me living with one alcoholic or two alcoholic or drug addicted parents. And so some people actually delay their age of first use because of running in families, they said, I've probably got the gene and I don't want to do this and I don't want to hurt my own kids. And then they end up in your practice because when they did finally sample something, loss of control happened, and it's really tragic. So, and you thought addiction was about drugs. I think it's about brains. It's about the hosts that these drugs work on, the vulnerabilities, also the resiliencies of that individual, what they have going for them. And obviously social determinants of disease are important. Some data I read recently is that the fentanyl epidemic is the first thing to really change racial issues in addiction. White people have generally considered that people of color use more drugs and alcohol than they do and have more addiction than white people. That has always been false. The problem is that with regard to social determinants of disease, when people with a lot of adverse life experiences and in tough socioeconomic situations, or with multi-generational racism, when they get a disease attached to it, they're sicker and they stay sicker longer. That's true not just with addiction, but with physical illnesses, psychiatric illnesses. People in minoritized populations, when they get these diseases, because of all sorts of issues, access to healthcare and treatment, but all sorts of reasons, it's a worse disease. So, but drug control won't do it by itself. We can't just control drug supplies and drug suppliers and supply chains. That's not going to do it. We must repair unhealthy brains and prevent vulnerable brains from undergoing the neurological changes into unhealthy brains. There will be a Nobel Prize won at some time that's going to show exactly what happens and how we can prevent it with regard to this brain switch. How is it that for, let's say 90% of human beings, they can expose their brains to alcohol, cocaine, and other things, and they just have repeat use episodes with no preoccupation, no loss of control, no use, just about adverse consequences. But 10% of the people, you expose their brains to these things, and you get these big rushes of dopamine coming from the nucleus accumbens. And what happens is the neuroplasticity is you turn on this cascade of events. It's like a cascade. And so the nucleus accumbens is recruits the hippocampus and the amygdala, the frontal lobes, all these things change. It's not the drugs that do it, because again, 90% of people can use drugs and the switch isn't flipped. But the switch is flipped in a certain subset of our population, and it's not their fault. And as far as prevention is concerned, having meaning in life is a big deal. And a lot of people who end up with addiction have lost meaning in life. I think we're going to need more perspective to really understand what happened in America after 1980. I mean, one thing that happened was Reaganomics and income disparities and multinational or the you know the transfer overseas of manufacturing and the tremendous economic losses in Appalachia and in the Rust Belt, and that happened, and people didn't have meaning in life anymore. And so the social and economic changes in our culture after the post-war boom really messed people up and set them up to get their reward through some kind of chemical. Communities change. I think Dreamland by Sam Quinones does a beautiful job of talking about that. At the end of his book, he gives his own opinions about connectedness and how reconnectedness is the solution in finding meaning in life. He gets it. And so, he's a journalist, no professional clinical training, no scientific training. He gets it, but he builds his whole premise around the loss of community in Appalachia that set everybody else up to get relief through these things. So what's wrong with the way we think about addiction? We see it as an acute problem, not a chronic disease. And we look at the complications of addiction rather than the primary disease. Doctors are taught how to fix livers, they're taught how to fix arrhythmias, they're taught how to deal with broken bones and burns. They're taught how to deal with hepatitis C and even the wounds from injecting xylazine. Doctors are taught to deal with the complications of addiction. Most doctors aren't taught about a primary disease. Addiction treatment focuses on withdrawal management and short-term treatments rather than on chronic disease management. And the success of treatment is judged very differently than treatments. I love this little cartoon from Tom McClellan. It's now 20 years old. It says, what if you have a drug that's going to treat high blood pressure? So you measure blood pressure before the drug, you give the drug, and then blood pressure goes down. Was that an accident or was it due to the drug effect? You take the drug away and the problem comes back. You give the drug again, the problem goes away. You take the drug away, the problem comes back. That sounds like maybe an effective drug. In addiction, we send somebody to rehab for 28 days, and then 6 months later, we measure the function. And we don't keep treatment going, and we measure outcomes in addiction treatment long after the treatment condition has been removed. And you would never do that. You would never design a study of outcome from diabetes 6 months after somebody stopped insulin. I mean, it's just insane. But that's the way outcome studies in addiction were developed. Hey, did the improvements stick? Sorry, sweetheart, they're not going to stick if you don't keep the treatment condition in place, which is why you need to stick with your patient over time. And so how do you manage chronic diseases? You don't cure them, you manage them. And you're not looking for a cure, but you stay with them. You have a relationship with the patient. And the key to success in addiction treatment is patient retention. If they don't come back, you can't influence them at all. So you should focus on functionality, not just symptom reduction, but functionality. And that's why the recovery definition of Faces and Voices of Recovery, which is about 15 years old, I think, says, I'm in long-term recovery. For me, that means I have not used X and Y number of years. And it means because of that, I'm able to function much better in my family and my community. That's the recovery definition from Faces and Voices of Recovery. Once again, I am in long-term recovery. To me, that means I haven't used in all this time, and that allows me to function better in my family and my community. And that's what you focus on. Okay. For all of the chronic diseases, again, arthritis, asthma, congestive heart failure, anything else, you want to have relapses be less frequent and less severe. And you want to have the period of remission be longer and have better functionality during those periods of remission. Those are the goals. And when we can achieve these goals with addiction treatment, we already do. Improving function during periods of longer remission. But if somebody does have another relapse after a long period of remission, do they throw in the towel? Well, no. If you fall off the horse, you get back on the horse and you ride again. And maintaining a relationship with the patient makes it easier for them to re-engage with treatment after a relapse than if they haven't seen anybody for their addiction in 5 years. Then they relapse and they go, what the hell are I doing? I'm so ashamed. I'm not going to go back to that provider, blah, blah, blah. So you want relapses to be less severe and less frequent, but to say they're going to be zero is, I mean, that's the ultimate goal, but there can be intermediate goals. This is the way primary care works. And so when I teach medical students, I say, just act like a doctor. And in medicine for chronic diseases, there's well patient visits. You monitor the status of remission in people with cancer. You monitor the status of the disease state in hypertension. You monitor people who've had melanomas. Seeing people for visits when you expect at the time the appointment is made that they're not in active disease is a legitimate use of healthcare. You have them check in with you, and how are you doing? And let's talk about your functioning and your relationships, and maybe even your connection to higher power. Where are you at with your sense of meaning in life? If you're using, again, it's kind of hard to talk about your sense of meaning in life and how things are going occupationally and how the kids are doing in school, because your use is dominating everything, once again, because it's the number one thing for you. So the only way to not get totally suffocating is to not dabble. And that's what I tell my patients. You can't dabble because loss of control happens, and it happens unpredictably. Most people after a period of abstinence will use and nothing will happen. And that will tell them I'm fine. They're not fine. They can't predict when they're going to trip the booby wire and the bomb is going to go off. So the benefits of sticking with the patient: early detection of relapse, detection of risk factors for early relapse, and then re-engagement in active efforts. Treatment is also secondary prevention. Treatment of addiction prevents organ damage. Treatment prevents substance-induced psychiatric problems. Treatment prevents suicide. Treatment prevents all sorts of accidental deaths, vehicular and otherwise. Treatment is a preventive medicine intervention. Self-help is very helpful, but it's not professional treatment. And we're out of time to go into any detail about these bullets.